a lot of traction on this specific topic involving value-based purchasing and the HCAHPS specific patient satisfaction survey. You know, just in line in terms of recruitment and candidate selection. You know, as long as maybe 2 years ago, we were giving this talk or a variant of this talk, and we would typically be in, you know, let's say it's a recruiting conference, and we'd ask for a show of hands. How many of you have heard of HCAHPS, even know what this thing is, and how it impacts the financial picture of your hospital organization? And maybe a couple hands would go up. I have to think that at this point along the line, especially since this whole system has really implemented itself as of last October, that you know, many of you are hearing this day to day. Sometimes HR and recruitment can be a bit separated as a business unit segment from good portions of the hospital. Unfortunately, all too often HR is left out of many conversations that are happening, and certainly this is one where HR and recruiting can really wield some influence and help move the needle in the right direction. So this is obviously a topic that's weighing heavy on the minds right now of the C-suite and the you know, the top administrators within your organizations. We know HR teams are in a great position to make an impact, and maybe more importantly, get credit for making an impact. So we put this presentation together just to share some of the best practices and some of the tools that you can use to help navigate the turbulent waters. I want to start by saying my background is in business development. I create a lot of content. I present and do a lot of the educational outreach for SkillSurvey. I will say, though, that this is a topic that gets very, very technical. It's somewhat political. It is you know, very litigious, and it's certainly an area where there are a lot of PhDs and a lot of subject matter experts that are crawling all over this subject and still don't completely grasp the full gravity of what's happening or about to happen. So I'm going to provide a very high-level overview, and we'll go from there. Hopefully your questions are not too technical, but if I don't know the answers, I'll certainly work hard to obtain those. I want to give you a little bit of background on us at SkillSurvey first, just to level set who we are and what we do. We've been providing reference checking solutions since 2002, so you know, it's about 13 years now. We've been you know, really we're proud to say we're the inventors of web-based reference checking. And some of you in the audience might be scratching your head a bit and saying, wow, I didn't even realize that was a thing, web-based reference checking, but it is. We have a patent pending on the technology. To give you an idea of scale, the various hospitals that utilize our platform around the world, really, put in almost 41,000 candidates last month. And compare that to May a year ago, we're experiencing some tremendous growth. So we've processed more than 1 million candidates since 2008, and we've touched over 5 million people, either as candidates or their references. We have over 750 customers around the world, and we check references. Really, the delivery method for the reference checking is essentially a job-specific behavioral survey. The difference is that the candidate does not see the survey, the references do. So the candidate chooses the references. Our system sends them a very specific behavioral set survey based on the job they're screening for. The references feed back the important behavioral data, how this candidate works under pressure, how they work and play with others, how do they receive constructive criticism, what kind of attention to detail, what's their professionalism like, all different things that really delineate this is what makes an A-plus player as an ER nurse or as a pediatric medical assistant or a phlebotomist or nutritionist or whatever role it is in the hospital. The surveys get very, very granular, and out of the 314 surveys in our inventory, we cover over 23 job families. 92 of those are for clinical healthcare roles. So let alone all the roles in your hospital that aren't clinical, like IT, like customer service, like accounting, maybe patient education. So there's quite a bit going on outside of the clinical. We're going to spend a lot of time talking about the clinical applications, but all of our our organization is really led by Dr. Cynthia Hedrick. She is our Chief Analytics Officer, our Chief Scientist, and her team of full-time IO psychologists are really the custodians of all of our data, watching trends, researching job competencies, utilizing all the IO research best practices in terms of formulating assessments in the form of these surveys. So it's quite an interesting space to be in. So that's a little bit about us. A bit about some of our healthcare clients. They're all different shapes and sizes. Some of the the household names in the hospital space, from the the large teaching hospitals, the children's hospitals, the university medical facilities, all the way down to small rural facilities as well. Maybe a hospital with only 25 or 30 beds. At the end of the day, a best practice is still to be able to discern whether or not a candidate has the vital behaviors and the behavioral attributes to be successful. Every hospital is really going to want the best and the brightest to come through their door in terms of onboarding. So we help facilitate that. So a couple of quick questions as we get started. Of course, I'm going to ask these rhetorically because we really don't have a direct feedback measure on this, but I'd have to think at this point a lot of you are familiar with HCAHPS. HCAHPS is basically where H stands for hospital, HH stands for home health care. So I wasn't sure if there was any home health care organizations on the call today from a caregiver point of view, but it's basically a variation on a theme. It's pretty much the same type of program. I'd have to guess that most, or at least a large percentage of you on the call today are familiar, and I'd have to think that slightly lower than that percentage would be number two. How many of you have HR programs and recruiting programs in place today that you can track and that are contributing to HCAHPS outcomes? And that's a little tougher. That's something that might be a little bit more elusive. So just in terms of our agenda, where we're headed today, we're going to overview HCAHPS. I'm going to give you a real quick and dirty overview on how this all came to be. Again, I'm not a government expert, but I can certainly tell a bit of the story of how it all came to pass. We're going to spend a little bit of time talking about the financial impact, and this is really the part that your CFO and your CEO really care about in terms of the dire threat to the financial picture. We're going to talk about the voice of the consumer or the voice of the patient, because in this type of context, we really have to consider that the patient is the consumer. They're the customer. And then we're going to talk in the specifics in terms of HR and recruiting and what are some things that can be tweaked in your recruitment workflow to help perpetuate some of this. So we're going to try to tie this all back into changes, hopefully positive changes that can be made on the procedural side of things in your organizations. So this all really started way back in 2002. There were a few different partners, basically government offices, that partnered together to create this value-based purchasing system. You'll see references to CMS, Centers for Medicare and Medicaid Services, as well as the AHRQ, the Agency for Healthcare Research and Quality. So the HCAHPS as an acronym stands for the Hospital Consumer Assessment of Healthcare Providers and Systems. And I underlined here consumer assessment because that's really the piece that you really have to understand from the jump. You're getting the scoring through the consumer assessment, through the survey that your patients are going to be taking post-discharge. It's a subjective view through the lens of the patient's experience. Again, it's their perception of what happened. It may not, in every case, be the reality of what happened, but again, it's the patient's perception. And that is what is going to be held in the balance here in terms of assessing payouts for Medicare and Medicaid. It's about the best thing, I think, that, or at least the most consistent system that they could come up with. And again, the consumer assessment piece in terms of patient satisfaction surveys, that's only a part of value-based purchasing. It represents about 30% of the equation, and that's the part that we're going to really talk about from a recruitment standpoint. So there's really three primary goals to value-based purchasing. There's the eliminating or reduction of adverse events, trying to keep bad things from happening. Okay, obviously that's important. Number 2, adopting evidence-based care standards and protocols that result in the best outcomes for the most patients. So the first 2 are more procedural. The third is just improving the patient's experience of care, which is certainly important as well. Now, the goals of this of the consumer assessment piece, really what they wanted to do was be able to create a way for prospective patients in the community to compare different hospitals in their area. So it allows for side-by-side comparison. Secondly, the ability to create a transparent system in which the public can see what they're getting for their, in terms of the accountability for the return for the public investment. And the old adage holds true that if you can't improve it unless you can measure it. So the public reporting of these results really creates the impetus to drive improvement. So it's really these 3 things. Giving consumers a voice, that in turn will improve the quality of care, and then ensure for the best public ROI. So it's really those 3 items as the cornerstones for this whole thing. So from 2002 to 2005, there was a kind of a continuous evolution. It went under lots of different levels of scrutiny. It really resembles this type of process is not all that different from a commercial enterprise, let's say a Fortune 100 technology company that's deciding to develop and launch a new product. There's all kinds of research, and then stakeholder focus groups, and a little bit of a trial and a reduced launch and a beta, and go back to the drawing board and tear it down and build it back up again and test it, and lots of tweaking and things. And eventually what they were brought to was in March of 2008, they had the first public report. So it took about 6 years to get to that point. So at least you can't say that they didn't throw this thing together half-baked. They took their time. The one criticism that I've heard, and I've heard this numerous times, different conferences I've attended, is that a lot of the actual physicians, a lot of doctors and physician advocacy groups feel as if the physician's point of view or the clinician's point of view were not taken adequately into account. I am not, I don't have the perspective or the context in which to say if that's right or wrong or indifferent, but I'm just throwing that out there that that's one of the prevailing opinions out there. So, there were a lot of levels of input that were taken into account here. Maybe the physicians and the clinical side wasn't as deeply sought after as it should have been. It's not for me to say. So the financial impact. This is really where all your administrators are focused. So these scores, the value-based purchasing scores, of which HCAHPS is a component, is going to impact the bottom line. And what it amounts to is that the Medicare and Medicaid reimbursements are going to be based on the percentage of that reimbursement is going to be based on hospital scores. So the big deal here is that based on the calculated score that your facility receives, that's going to dictate how much Medicare and Medicaid subsidy that you receive. So that's one level. Now, when they think back to 2002, the economy was okay. It's going pretty well. Things were pretty solid, pretty stable. Now we're coming out of this recession, and now in the midst of this recovery and trying to get the the economic engines firing again, now we have this to worry about. So obviously there's no way they could have envisioned this way back when, back in 2002. But we're all fighting reduced budgets as it is. We're trying to do more with less, and now you get the word. Some of you have probably already heard this coming down the grapevine in your organizations that, hey, we're going to have less to deal with. Or what about sequestration? What about healthcare reform as a whole? What about holdbacks there? Developing a war chest. So, certainly there's a financial picture to this that is probably larger than all of us. So who pays for this program? Well, CMS, the way this is going to work is that CMS is going to withhold 1% of Medicare reimbursements from everybody in 2013. So if you take 1% off the top from the pool, that's going to create a pool of funds, about $850 million or so. So essentially this is going to be redistributed to hospitals based on how well they perform. So some hospitals are going to get docked, and other hospitals are going to actually get rewarded if they are above the above the waterline. Now, based on what I've seen, it seems as if you're more likely to be penalized than rewarded, but it's a 1% holdback for those Medicare reimbursements, but that's going to increase by 0.25% every year until eventually it reaches 2% for fiscal 17 and thereafter. So, it's going to get increasingly a little bit more painful year over year. Now, adding to that, CMS is also going to do some adjustment to the rates based on hospital readmission rates and hospital acquired condition rates. That kicks in a couple of years, but the readmission rates are in effect for fiscal 13. So I'd like you to file away the readmission rate issue, because that's actually something in HR and recruitment we can maybe begin to soften the blow with. So you might be wondering what the current national average is against the VBP benchmark. How well are facilities doing? And actually the national average right now is just a shade over 55%, which isn't great. So, there's also a statistic, it's a bit dated, floating out there that on the VBP benchmark scale, I think you needed a minimum score of 70. And if you ask me what the 70 represents, it's not a percent, it's a point-based system. The national average not all that long ago was a 53. So that's a little bit higher than 55%, but I'm not sure how these numbers differ. But suffice to say that the average hospital out there is underwater. And what that does create is an aggregate risk of almost $900,000 in 2012, and then $6.67 million over the next 5 years. So the value-based purchasing is how Medicare is going to be paying out from now on. And one way to look at it is the top performers are going to make money, the poor performers are going to have money taken away, and that may not be completely equitable. And there are a lot of factors for why scores might be low in some of these areas, and some of it's controllable, some of it may not be. But the bar is going to keep being raised as the nation improves and as measures evolve. And ultimately, this is designed to hold the feet to the fire to improve care and account for the public investment. So let's get back to readmissions for a second. I mentioned readmissions and how they're important. They're going to actually be part of the figured equation as we go forward. This is really where the human element, i.e. your talent, your employee base, has a big opportunity to help. Much of the readmission is due, much of all readmissions, according to research, is due statistically to patient education at discharge. Clear communication, answering questions, assessing the understanding of patients and their families, it's very key. There are root behaviors and there are soft skills present in that skill set that can make or break how successful an employee is. How well can they pick up on, hey, are you getting this? Do you understand what this instruction means? Or do you there's a lot of the educational process that happens right at discharge that really, bears in a big way on readmission rates. And as a matter of fact, readmissions cost us $15 billion a year. They say that within 30 days of discharge, 18% of patients walk back through the door. Now, the thought here is that if there's a way to level out or normalize the variation between city and rural and income areas and different socioeconomic factors, if you can kind of level out the high spots, the savings can be over $100 billion over 10 years if the high-cost areas are brought to the national average. There's a thought here that 75% of all 30-day Medicare readmissions are potentially avoidable. That would save $12 billion a year. So obviously not all, but many readmissions can be preventable. And there's some significant savings available there. AHRQ issued a report. This is dated. This goes back to 2009, but I think this still holds up. Patients that have a clear understanding of their aftercare instructions, including how to take meds, when to make follow-up appointments, are 30% less likely to be readmitted or visit the ER than patients who lack that information. So I think solid patient education is the key. It's an opportunity not just to achieve on the financial side, but also to raise satisfaction across the board. So nothing dulls the enthusiasm of a patient having to come back in again. That goes for sure. So let's move on to the voice of the consumer, the voice of your patient. There's obviously going to be a big impact from the HCAHPS scores, which we need to understand how it's measured and really why the model is the way it is. So again, the CA in HCAHPS stands for consumer assessment, and that voice of the patient's never had this much power before. It's unprecedented. And it's funny because regarding whatever type of service is out there or product is out there, if you go shopping for a car, you're looking for home service in terms of tradesmen, like a plumber or HVAC company. You have to change dentists. A lot of us, when we change dentists or doctors, unfortunately, it has to do with who's in our insurance network. But you're always on the lookout for how good is that dentist? Who you're going to ask? You're going to ask your friends, your network. And the old way would be to pick up the phone and do it. But the new way, it's just so easy nowadays with the proliferation of social media. There's a variety of different ways to get on and get impartial third-party feedback in terms of, what about this vacation destination? What about that restaurant? They're saying that Best Buy right now is really having trouble and struggling financially because it is the world's best showroom. Because people go into Best Buy, they pick up the gadget, they play with it, and then they zap the QR code or the UPC code on the tag, and they get on the Google Shopper, and they find it for $30 less with free shipping online. And then they're able to read reviews on it. So a lot of times you're reading the review, maybe you're going into your sticks and mortar store to go look at it and play with it, and then you pull the trigger online. So the way consumers just go about their daily consumption is different nowadays. Reviewing is the new advertising. I wouldn't dream of buying a new TV without jumping onto Amazon and reading reviews on it. So obviously the usage is growing fast and it's spreading quite a bit. And healthcare is the same way. Consumer Reports has their own version of doctor ratings and medical facility ratings, and their format is pretty good, albeit it's a little bit more subjective. It's not completely always apples to apples, but the one that we really have to worry about here, and I just took these more recent screenshots, this was completely redesigned not too long ago, is hospitalcompare.hhs.gov. It's funny because I actually, for a moment, I forgot that website and I tried to Google it, and it's not very search engine friendly. Again, probably pretty typical of a government operation, but you actually have to do a little digging to find it. But hospitalcompare.hhs.gov will get you there, and this is simply the repository for all of the HCAHPS data. So you can compare your hospitals. You can look at all of your options available to you. So right off the bat here, what I decided to do is, I live in the very northernmost tippy-top region of Delaware. I'm maybe a quarter mile from the state line to Pennsylvania. So what I decided to do is just throw in my own zip code. And what it allows me to do is just go locally here and compare hospitals. You can compare up to 3 hospitals. So they give you a little map, and I can widen the geographic search if I want to. I can limit it to a state. So I just grabbed 3 hospitals that were pretty close to mine, and I compared St. Francis, Crozer-Chester, and Riddle Memorial. And what this, I just took some screenshots here of actually the results from the HCAHPS surveys and from patients that have been served at these different facilities. So patients who reported their nurses always communicated well. So you can see there's a range here, and over on the right side, you see on the yellow the yellow side of the graph, it's the average for all our hospitals reporting in Delaware, even though 2 of these hospitals are actually technically in Pennsylvania, and the average for all the reporting hospitals in the U.S. So 78% seems to be the magic number, and you have, Riddle is a little higher, Crozer-Chester and St. Francis are a little bit lower. That's interesting. So I'll take some more. There's actually another corresponding slide that I didn't include here that has to do with doctors, how well the doctors communicate. Patients who report they've always received help as soon as they want it. You can see this is quite a bit lower. Patients who report that their pain was always well controlled. This is obviously a concern. Patients who reported the staff always explains about medicines before giving it to them. That's a real darn important one, and certainly a bit underrepresented here. Patients who report that the area around the room was always quiet at night. So the way that they actually word these questions from an assessment standpoint is that word always is very important. And I'm going to come back to that because the way that they actually structure the questions from a survey point of view is purposeful, and it really puts the pressure on the institution to produce consistently across all shifts. And that's a change. That's a change from what a lot of patient satisfaction ratings are used to. Patients at each hospital who reported that, yes, they were given information about what to do during their recovery at home. Now, this is pretty high. So it'd be tough for a patient to say, no, I was given no idea what to do during my recovery at home. That would be a stretch, obviously, but still very important metric here. And then rate your hospital on a scale of 9 to 10. I'm sorry, rate your hospital on a scale from 0 to 10, 10 being the highest. And these are hospitals that received a 9 or a 10 on that scale. And you can see there's definitely some disparity here. Now, this last one is probably the linchpin. Patients who reported yes, they would definitely recommend the hospital. So the national average for this had been hovering at 70%. I'm happy to report it's ticked up 1% to now to 71%. But for about a year, maybe 15 months, that was sitting at 70% and not moving. And they refresh these statistics, from a reporting standpoint 4 times a year. But consider that that's still less than 7. You're 70% or less. Your patients that leave are saying, yeah, I'll go ahead and recommend this hospital to a friend or family member. That's still 30% or more that are saying no to that. That's troublesome. If I were a hospital administrator, I'd be really concerned about that. So that's just a look at the survey, how some of the questions are architected. And again, that's pretty. They knew what they were doing when they put the survey together because the way they've built those questions is on purpose. So let's look a little bit at some of the patient satisfaction efforts that your organizations are undoubtedly undertaking, and I'm sure that every organization is doing something along the lines of the food, the parking and the valet situations, even the options available for visitors, coming to pay visits to loved ones in the hospital. I'm sure many of you have seen these changes and seen this evolution toward almost what we're learning from our friends in the hospitality space. The curb appeal of the facility, the landscaping outside, the ease of entry, how they're greeted, how they're brought to their rooms. It's almost like checking into a Hilton or a Marriott, and that's a good thing. Obviously, there's a lot of benefit to that. In general, I wanted to take a look at the emphasis being placed on the patient experience, and 72% of healthcare leadership stated that they're doing, it's more of a priority this year as opposed to the past years in terms of the patient experience. So, who's doing more, and who's in charge of that, and who's actually executing on it. This was pretty telling as well. In your organization, who owns the patient experience? And the majority, the runaway is here. It's a multidisciplinary team of leaders and clinicians and staff. It's not one person that owns it. We all own it. That's pretty easy to say, but ultimately, maybe the buck stops at the CEO. I've seen more and more positions created that have some sort of a title that resembles patient experience director or vice president of patient experience, or something to that effect. The CNOs here, the frontline staff, the chief operating officer, the chief marketing officer, it comes in at 2%. But there's one thing wrong with this. There's a missing department that's not represented here at all. Anyone want to guess what that is? It's where's HR and recruiting? There's no mention of us here. What's going on? How are we left out of the party? And you all do a lot in HR from a practitioner standpoint, from a recruiting standpoint. The screening and assessing of new talent, the hiring that talent, and then HR takes over, and in terms of the onboarding and development of that talent, and then managing it, through that employee life cycle, from onboarding to offboarding. So, there's certainly, an opportunity that if we can really tighten up what we're looking for, what we're seeking in a candidate, do we know what we're looking for? How are we assessing this? How are we interviewing for it? Are we basing our decisions closely on this new information that we're now considering for the first time? These are all things that we really need to begin to consider, because if there haven't been material changes made to your recruiting workflow, I would say in the last 12 to 18 months, if you haven't done something radically different or at least somewhat different, then it might be time to really look at this, because a lot has changed behind you. You're at the the front door, or in front of the front door, if you will, from a employee standpoint. They have to go through you to get in and get hired. If everything else behind you has changed, has the recruiting workflow up front changed? And in some cases, yes. In other cases, no. So go back to the survey for a minute. What is measured? Well, in the survey, we've identified 8 different themes. And we've done a deep dive into the survey and torn it all apart and really looked at what's asked and how it's asked. And really, of the 8 themes, there are 4 of them that really come down to, that we feel hold the most sway in terms of what can we recruit on. Nurse communication, physician communication, medications communication, and staff responsiveness. The cleanliness, the quietness, the discharge, that's more stuff. That's that's more procedural. But in terms of behaviors, listening and communication, patient empathy, compassion, these are the soft skills and the behavioral themes that are really the most vital. Some of these speak to an employee doing a good job, and that's very important and incredibly vital. But we're more interested in the stuff that's harder to pin down. Now, I mentioned, up till now, Ganey, I'm sure most of you, if not all of you, are familiar with, was pretty much the incumbent patient satisfaction yardstick. And when HCAHPS came up, a lot of people assumed, oh, well, it'll just be pretty much like Ganey. And that's true to a point, but the traditional Ganey survey focuses on patients' perceptions of the quality of the care from very poor to very good, from a rateable scale of 1 to 5. HCAHPS is going to measure patients' perception of how often they received high-quality care. So the difference here is, in terms of a term like always, and that was how those questions were worded, in terms of the way they were asked. And HCAHPS is looking for consistency. It's looking for thoroughness. It's looking for, utter consistency across the stay, where Ganey generally tends to be concentrated more in terms of a snapshot in time. They're very different mechanics. Now, a hospital that rates extremely well or even off the chart in terms of what Ganey rates, then, odds are you're probably going to do pretty well in HCAHPS too. But the difference is that it has to do with consistency. 1 or 2 rock stars on that one shift are not going to get you by from a data standpoint, from an analytics standpoint. So we know HCAHPS is strongly linked to behaviors. We've just talked about that. The question becomes, is it an exercise of training existing employees, and or hiring to fit the model. Well, of course, you can't fire all the employees and hire new ones. No one would advocate that. In reality, you're going to do a little of both. You need to keep in mind that training is quite effective for hard skills, but does not always show up well in terms of training for behaviors. If you think about it, how do you train somebody to be more compassionate? You can train them to run an IV or administer a catheter or a certain tab A into slot B type of procedure, but you can't really train for compassion. It's just, it's there or it's not. And that's an example of the difference between training existing employees or hiring to fit that model. I guarantee you in some of your facilities you have RNs that are that have all the technical know-how and ability, but they just maybe lack something on the behavioral scale that maybe you knew that going in. Maybe you probably didn't, but our job at SkillSurvey is to try to open up a window into the inside of the behavioral set of a candidate to make better decisions from that way. So a lot of employees are going to be hardwired. They're hard to change from a behavioral standpoint. You can send every single employee to a motivational training seminar. It might have a little bit of effect in the short term, but employees are gradually going to revert back to what, quote-unquote, normal behaviors. So let's talk a little bit about, from a process standpoint, hiring for HCAHPS excellence. So your talent acquisition workflow from a recruiting standpoint is going to look a lot like this. You do your sourcing and you do some pre-screening, and then you go ahead and you maybe whittle it down to a smaller group. This is probably the group that you'll do in-person interviews with. You have some sort of assessment instrument at play here, whether it's psychocognitive or personality assessment or rating some sort of potential, and then ultimately hiring the right person. So that's probably pretty typical and normal today. So how about interviewing for HCAHPS? Will this candidate that you're sitting across the table from, will this candidate help the organization raise its scores? How many of you use behavioral interview guides? And I have to think at least some of your interview questions are probably going to be tinged with a bit of behavioral-based interviewing. How many of those guides or those resources that you utilize have anything to do with HCAHPS whatsoever? Unless they're fairly recent or been recently reviewed or overhauled, my guess is not many. And lastly, are all of your managers equally skilled at interviewing? It never fails. Whenever I show that little drop-in on this slide having to do with managers interviewing, in a room full of recruiters, you interview all the time. You phone screen constantly. Your spidey senses are so well attuned to what you're hearing and more likely what you're not hearing. Managers sometimes have no idea, and they have the best intentions sometimes. Sometimes the best managers of people, the best leaders, are the worst interviewers because they don't have a turnover problem. They're great to work for, and they have extreme loyalty, and people come to work and they're excited to work with your best managers. But if you're not interviewing on a regular basis, it is true what they say. You can use it or lose it, I guess they say. And how well do your managers tell your story? How well do managers frame the culture? How well do managers really take the candidate through? This is a day in the life. This is what it's like to join our team. This is really what we need you to be, and this is what we expect. That's a tough story to tell. How consistently is that being told or conveyed by your managers across the organization? So examples of some HCAHPS questions. Tell me about a time when. That's a great way to start. Explain to me or walk me through a moment in time when you had to do this, or give me an example on by the bedside at discharge, you had to change your style of communication based on the patient or their family, or walk me through a typical discharge. Just make it up. Just walk me through how you would approach it. These are the common denominator here is that the answers to these questions are very difficult to fake. You know, our job, the job market right now, and the you know, the candidate pool that's out there, those resumes that are coming across your desk, we probably never had a moment in time where we had such a very prepared job candidate pool. These people are used to interviewing. They're kind of good at it. They're pretty decent at representing themselves, and they have a lot of the answers to your questions. From a biographical standpoint, they could talk about their resume and stuff, but when you start throwing behavioral-based questions in terms of give me an example of, or tell me about a time when, that becomes a little bit more difficult to fake. Now, from the candidate assessment perspective, behavioral assessments, we at SkillSurvey, it's obviously a little bit different. I mean, we're assessing behavior, but we're not doing it from the candidate perspective. That's the difference, and that sometimes you know, takes a little bit of explaining. But most of the candidate assessment tools that are out there, some of them are a bit old, and you have to make sure that whatever you're utilizing has been brought up to speed and made current in terms of what HCAHPS is all about. Because if they're, you know, more than 2 or 3 years old, a lot of that, you know, a lot of the assessments that are out there, the more popular ones, predate. The other thing to think about with self-assessments, there's 2 things. This is completely through the lens of the applicant, and you know, that's one way to go about it. These things will show you potential. These things will show you can this candidate do X, Y, and Z, or do they have the potential from a personality standpoint, or you know, what's their high potential watermark look to be. The other thing is that they can be gamed. It's been proven. There are books, there are online blogs and study courses in terms of, you know, if you're taking a Myers-Briggs and you're not necessarily an ENTJ and you want to be, here's how you can answer the questions to get there. So we think, you know, our point of view at SkillSurvey, we think self-assessments are definitely a piece, and when they're used, they're obviously a component of the whole picture. But I'd be more interested in knowing, rather than potential, and can this individual do the job, I want to know, have they done the job? I want to know what their former managers think. I want to know what their former coworkers think about how this individual is under fire day to day, not how they're at taking a test. So can references help you with that? Well, of course they can. Reference checks can definitely paint the picture, and especially when those reference checks are tied to HCAHPS. So you might be thinking, all right, well, how in the heck do you tie a reference check to HCAHPS? What's that like? And we've done that. References are the only ones that are really positioned to be able to tell you, has this individual, you know, exhibited these behaviors in the heat of battle, not just on their best day, but also on their worst day. You know, they've managed this candidate before. They've worked side by side in the trenches with this candidate. Wouldn't you like to know what they know? So if you do reference checking and you do it the old-fashioned way by telephone, if you're able to get any information, which nowadays is really tough to do over the phone, a lot of times you'll get dates of employment. You will get, you know, yes, they worked here from this date to this date. You might get rehire eligibility if you're lucky. But in terms of interpersonal skills, talk about work ethic, talk about their personality, were there any incidents in their background in terms of violence in the workplace? Maybe. You're very unlikely to get much of that at all. And this is all the good stuff. This is all the stuff that really makes the candidate tick. And this is really, if you can get a handle and throw a rope around those different attributes, understand them, and then begin to screen with that as a factor, you're talking about, beyond HCAHPS, you're talking about lower turnover, you're talking about you know, elevated levels of job satisfaction and hiring manager satisfaction, and this is all the good stuff. This is all the stuff that is real tough to get, but you know, fortunately, it's you know, is really what can help you out in the long run. So we're trying to drive as much of that information to you as possible and into your hiring process as possible through reinventing the reference check process. So in terms of improving the quality of hire, references perceive that as much as 15 to 20% of candidates are going to have developmental needs that may impact HCAHPS. So typically our breakout when we look at a behavior, a specific behavioral attribute, a lot of times, I would say 80 to 85% of the time, you're going to, you have a good feel for the candidate. They interview well, they pre-screen well, the references will agree, and they have minimal developmental need. That would be the green bar. The yellow bar would be some sort of moderate risk. So it's not terrible, not completely awesome either, but somewhere in the middle. And what we find a lot is that, heck, if you have some more highly qualified candidates from a behavioral basis, maybe you don't go this way. But in a pinch, if it's a tough to fill position, or maybe there's a story here. There might be something that's coachable with maybe some modified onboarding. The employee might have a very high ceiling from a potential standpoint. Maybe you take the risk. Now the red bar here really denotes developmental need of a profound level. So these candidates are obviously avoidable and high risk, and proceed with high warning. Now, in a recent survey, a recent sampling, I should say, of RN candidates that have come through our system, almost 13% of RNs will score low on behaviors that we have linked to HCAHPS. So again, you have about 87-ish% that are high. They are who you think they are, and their references agree with you. But the medium to low, these are the areas that obviously need a bit of watching. So a lot of folks are surprised when they say how somewhere between 12 and 13% of RNs right from the jump are going to be deficient in HCAHPS attributes. We also did a bit of a study here on high-performing candidates, in terms of HCAHPS-related scores versus low candidates. And what we found were that candidates that really were high-scoring, based on what their references told us, are 51% less likely to be terminated involuntarily. So this was a study of 4 clients, 4 SkillSurvey healthcare hospital clients across their clinical positions. So it demonstrates that the HCAHPS survey is probably evaluating the right behaviors. The question becomes, how effectively are organizations evaluating these specific behaviors in the pre-hire stage? And I can tell you that when we talk HCAHPS again, I mentioned it before, it really has to do with listening, has to do with communication, and it has to do with patient respect. Those are really the 3 touchdowns. And there are some others that are contributing, but those are the 3 primaries. We've actually gone so far to develop an HCAHPS reporting cluster. So we call our system Pre-Hire 360, and it does exactly what it sounds like it should do. It is designed around an employee 360 review. The only difference is that this is being conducted pre-hire, so it's like getting a full 360 behavioral report on a candidate that doesn't work for you yet. They're still a candidate, and it's all through the lens of the references, the previous managers, the previous coworkers. What we've done is we've taken our survey questions, like let's say for an RN survey. We have several different variants of RN surveys. It's a very deep library there. But let's say it's an ER nurse. We've done the research in terms of what makes an A+ player, in terms of a top-level ER nurse. Now, going one step further, we've done the research to link specific behavioral themes into long-term success for patient satisfaction, and we can break this out as a separate reporting cluster. So we're talking about areas like professionalism and interpersonal skills and problem solving and adaptability. We've layered HCAHPS on top of that, so it's a separate perspective. So you can see these questions really center around how do they instruct patients on home care procedures, how do they communicate, how do they listen. Very important stuff to know. Now, we've also tracked that almost 10% of RNs are going to score low on HCAHPS-related behaviors, and that's a bit of a scary thing. So, you can't just assume that everyone walking through the door is going to be solid in a lot of these areas, because it's just not the case. We just published a new research study that hospitals that use SkillSurvey Pre-Hire 360 for reference checking, those applicants statistically outperform hospitals 9 out of 10 areas of patient quality that HCAHPS measures. So hospitals that are utilizing SkillSurvey as a reference checking solution are doing better on the HCAHPS surveys than hospitals that are not. And that report and others are available on our website. It's a sample of 125 different SkillSurvey customer hospitals compared to 147 non-customer hospitals that are matched, roughly equivalent in terms of revenue and numbers of beds and all that, try to norm out all the variables. And it involved about 80,000 separate data points. So it was a pretty deep dive study, but it was conclusive that 9 out of 10 areas there was market improvement. So let's summarize and take a step back here, maybe save a few moments at the end here for some questions if we have them. We would say that probably the first order of business in terms of assessing where HR can help is really understand what's measured. If this has been the first exposure to the actual survey itself, jump onto that hospitalcompare.hhs.gov website and look at the survey and look at the results of the questions and put in your own zip code of your hospital and compare yourself to your two neighboring crosstown facilities that you're fighting over for patients and probably even fighting over for staff as well. Look at where your score is and be realistic. Where are you falling short? Where are the gaps? Now, from a patient satisfaction standpoint, what does that mean? Well, I think once you identify where those gaps are or where those gaps exist, again, it's nothing necessarily you did to create that or nothing HR or recruiting did, but you can certainly take a look at, hey, are there some little tweaks, some little massages we can make to our process to maybe center some more questioning around some of these gaps. Maybe we can make up some room. It doesn't take a whole lot, and you're really talking about something that's low cost or no cost to do. Any kind of changes, whether that's utilizing automation, something like SkillSurvey, or maybe tweaking your assessments a little bit to make sure that they're brought up to current. Any kind of change, you're going to want to clue everyone else in around you. Obviously, monitor any changes in your score, and then when things begin to improve and you push the needle up, shout it from the rooftops. Communicate the success. I mean, it's not often you get a chance to do that, but I've had it shared with me numerous times by some of our customers to be able to go into the BI dashboard in our platform and pull out a bad hire avoidance report and be able to march that down to your CFO's office and say, oh, by the way, in the previous quarter, we avoided 6 bad hires that a year ago this time we would have completely offered them positions. We avoided 6 poor performing candidates, and based on the average annual salary, we saved X. That's a pretty powerful chip to be able to play from an organizational standpoint. So anything you can do to communicate your success or portray that success in terms of charting the improvement, measuring it, all the better. So I would say I'm about complete at this point, but my email is here, as is my LinkedIn. So I'm a huge fan of LinkedIn. If you'd love to connect, please look me up because I am there. But what I'll do, Noel, I'll go ahead and throw this back to you. I'm not sure if we had any questions come in.
Yeah, we do. We have a few, so let me just put them together. You were answering some of them as you went along there. So let me just see if I can filter a couple of these. One good one I thought was, are you seeing this data being used in marketing to new hires, actually putting out there the HCAHPS scores, I guess?
I haven't specifically heard of that. I know, I mean, a lot of times hospitals will play up their magnet status, or certain accolades and things. I think HCAHPS might still be a bit new. There are students coming out of nursing school that still don't completely understand what it is. Unfortunately, there's still a lot of folks in hospitals that don't completely understand what it is. So I just don't know if it's trickled down to that point yet. It wouldn't surprise me at all if it happens in the real near future.
Me either.
And
Yeah.
I think it's such a competitive market that if there's an additional feather you can put in your cap and help a candidate discriminate between, hey, do I want to work here or do I want to work here? Obviously, I want to work where the satisfaction's higher. That's a better organization. And it makes a lot of sense that an organization would want to do that.
Okay, and another question, simple, but I'd like to know the answer myself. Can anyone see this data? Is this the HCAHPS scores? Is that pretty readily available on those websites you listed?
Yeah, the hospitalcompare.hhs.gov. In fact, I'd be surprised if a couple of attendees listening in today didn't open up an additional window and pump that into their browser.
Right.
But yeah, it's all out there. I mean, there's no gate in front of it. It's all out there in front of the public. All the the good scores and the dirty laundry. It's all out there in the wind. So you can totally see. And again, that those scores are updated I believe it's every quarter. I think it's 4 times a year. So.
Okay.
You can definitely see how it changes, and the system implemented in October of 2012, and that was when fiscal 13 started. And we've now gone past 2 quarters now, and there's been a rush. Like every time the scores come out, there's a bit of a flurry, and we hear stuff, and it's all secondhand through our customers, but it's significant, and I think there's a lot of hand-wringing and breath-holding when those scores update, and there should be. It's important.
Definitely, and actually someone asked a question which I thought was interesting too, is do you know where to find some of the recommended behavioral questions that should be asked of employees? And I imagine some of that done through your offering.
Yeah, it is actually. There's no shortage of real good resources out there and vendors available to you the behavioral assessment space is obviously well traveled, and there's some organizations out there that do a phenomenal job at it. SkillSurvey, we actually grew out of one of those organizations. A lot of our founders and lead executives came from that space. So the only difference is we're approaching the assessment not from the candidate side, but from the references side. It's a little bit of a different spin, and that one of the things we do as part of the candidate report, once the references all weigh in, we aggregate all that data together. We blend it all, so the references also know this, so they freely speak candidly about the candidate because they know they're safe. They know their name's removed. It's basically anonymous, but we'll get 4 former managers and 3 former coworkers, get all their responses, blend them all together, and then issue their behavioral report. And then aside from each behavioral cluster, we will actually tee up behavioral-based interviewing questions around those behaviors. So it's nice to be able to look and say, all right, well, this is what the former manager said this candidate was: strong, weak in, somewhere in the middle, and here's some questions to maybe help flesh that out a little bit. So that was a key addition. We just added that last year, and it was well received. So
Okay.
there are lots of resources out there beyond ours that are readily available.
Would you say it's actually better to hire someone and train them in the skill set necessary for patient satisfaction scores, or is it better to get someone who kind of already has that in place, that's already been trained?
If all things were equal, and things are never always equal, but if I had candidate A who was very was stacked with experience, they had they did their clinicals, they just had a tremendous handle on field experiences, and they spent lots of time on the rounds, and they just knew their way around. And I had another employee that maybe was a little bit shorter on that experience, but they were off the chart from a personality and a behavioral standpoint. They had empathy and compassion in spades. They were deeply drawn to the calling. I would always look to go more for the second type of candidate rather than the first, because you can train them on those hard skills, especially if they're deeply intrinsically motivated to be there. You'll be able to get them where you need them to be. Now, unless there's some real deficiencies on the hard skill side, but oftentimes there's not. And a lot of those are the skills that when you train them, they stick. That's experience. But it's more the left brain versus the right brain. So the analytical tab A and the slot B mechanical side on the left side of your brain, the right side is all the emotional intelligence. Well, it's hard to change. It's hard to change that behavior, and it's hard to train it into somebody that doesn't possess it. So I would definitely take my shot with the candidate that has the more higher emotional, more EQ, if you will, and look to get them there. And maybe it might take a little longer to onboard them and get them to where you need to be, but I think the end result is going to be better. And that goes for sales, and that you can really translate that into any calling beyond healthcare.
Absolutely, and I was thinking too about, you mentioned a SkillSurvey study. What were some of the areas where the SkillSurvey hospital scored better?
There were 10, and I know off the top of my head, it really emanates directly back to the HCAHPS questions that the patients are answering. How often were they given information about what to do during the recovery? How often doctors communicated well? How well they received their assistance quickly when they rang the call button? How well the staff explained medications. It was all those areas that had to do with the behavioral side. Less about the noise and things, but some of the things that are more actions rather than behaviors. But there were 9 of 10 areas which we felt was pretty compelling. So definitely where there's that much smoke, there's definitely fire behind it.
Yeah. And I guess the last question to throw in there is, a lot of this relies upon references and them providing the information. Do you find that the references really respond to the questions?
Yeah, you know what? It's funny, we do. And when we tell people somewhere between 85 and 90% of references actually, they get this email, and it's really an email from their candidate, or from the candidate you're screening. So the reference knows the candidate well. They worked with them. They managed them directly or worked with them side by side. And they don't know you, the recruiter. They certainly don't know SkillSurvey at all. So it's the delivery of the email message. Hey, can you help me out? Can you be a reference? Click on this link. It'll take you to a short survey where you'll rate me on my behaviors from when we worked together. By the way, I've released you from all liability, so I'm not going to sue you for participating or your organization. And this is a personal reference. You're not responding as your official HR reference. So your responses are aggregated in with the rest of my reference group, and that's how the report is issued. So we'll know who responds, but we don't link specific feedback to one reference or another. And the way we bring that across in terms of the experience, the reference, they go, oh, you know what, this is no big deal. This will just take me a few minutes to do, and I'll knock this right out. So it's quick, it's easy. We actually are finding a surprise once we mobile optimized the process where you could take it on a smartphone or a tablet. Everything, the speed went way up, and a lot of candidates and references are actually doing this right on their smartphone. So it's definitely an example of how new technology can just take an old, broken, fractured process of reference checking, calling somebody on the phone and stalking them, and when they're really not, they're too busy to really talk, but they could take a survey in just a few minutes. It's a little bit more arm's length, but you're able to create like a frank, candid feedback portal. It just works so much better. And yeah, 85 to 90% of the time, we're getting the references to respond. So if you ask for 5, you're getting 4 back at least. On average, we get 4.5 back per candidate. And we're able to actually finalize the report within 2 business days. So, I mean, it's a lot of times that we get a lot of skepticism when we say that, but on the broad basis in terms of our system metrics, it's 4.5 references, and and the reports are done inside of 2 business days. And you just can't do that over the phone. It doesn't happen anymore, not today. So it's powerful, and it's certainly easy to do, and it's becoming more and more accepted.
Well, I know. I mean, I encourage everyone, all the attendees, and everybody who comes through recruiting blogs to go ahead and check out SkillSurvey. They have an excellent product. And Brian, you give a great webinar. Really good job today. Thank you very much for this. Our audience appreciates it. Everyone who's attended, if you didn't hear at the beginning, we will send you an email with links and follow-up to all of this. Brian would very much like to hear from you all, so feel free to email him or connect with him on LinkedIn. And of course, always stop by recruitingblogs.com and check us all out. Really appreciate it. And thank you so much, Brian.
All right, Noel. Have a great day, everyone.
Thank you. You take care.
Thanks.